Thank you so much. So Adult Care 2030 is the title of what we were asked to speak about and reflect upon. Next slide, please. And actually, there were 3 exam questions in this. One was, how has COVID forced social care to change? What should be the priorities for change to kickstart evolution of adult social care development? And then if you could visit 2030, how would you hope the experience of being older and disabled or caring would be better? So what I figured was the first and the third you're all expert at. And perhaps I can maybe address a few comments on the second point, which was what might be the priorities for change. So next slide, please. So priorities for change, what I'm thinking here is that there are obviously immediate priorities, and there are some short to medium term to long term priorities. So on the immediate, obviously, you know better than I do about the short term funding for providers and councils, which should be linked to demand. There's clearly a chronic and acute workforce shortage, and clearly there's a need for much greater infection protection given the COVID and likely second wave. On the short to medium term, which is what we're meant to be thinking about 2030, obviously the key issues here relate to financing and reform, but overall underpinned by a strategic vision about what we want social care to look like. There's issues about addressing in a long-term way a sustainable workforce to address the shortages, perhaps have more homegrown workers. There's also a lot of work to be done on how social care integrates with other service providers, and clearly close to home for me is the NHS, how it does that, including how it shares data with the NHS. Then, most best use of social care through better prevention and boosted domiciliary care aided by technology, just as James has alluded to. So I'm just going to make a few comments about some of these areas. Next slide, please. So the immediate side, and next slide, please. So ADASS has been very, very active through its budget survey, looking at what's happened to revenues to councils over the last 10 years or so. And probably this doesn't need to be rehearsed here, but I think you can see over the last 10 years, it's been pretty nasty, with particularly the 2010 to 2016 being the biggest fall, and a slight bounce back since then. So cuts everywhere, largely because, as you know, of the revenue support grant from central government, which is 20% overall of council's funding. So really, it's been not a very nice picture, and I'm sure you all feel that and can see it. Next slide, please. And as you also know, funding hasn't kept pace with demand. So this graph here shows you over time, since 2010 for the last decade, what's happened to overall spending on adult social care services relative to 2010. And you can see that overall spending declined over the period, but slightly picked up again after 2014-15. But spending per person, per capita on adult social care services fell by 12%, as you can see. And if you age adjust it, take account of older people, particularly the increasing needs of age, you can see that it really has fallen a lot more. So that's the picture. I know you know that, but that's just to show it in graph form. Next slide, please. Next slide, please. Yeah, and the spending per person, as you saw for adult social care, has fallen, but actually I think this is quite useful to show that England, the spending per capita is actually a lot lower than it is across the rest of the UK, and this is probably because of historic, the Barnett formula and choices within different countries as to how they spend their money, but you can see the differential there is not insubstantial. Next slide, please. And what this rather busy slide, I think, here shows you is the change in net spending per person over the last 10 years, more or less, by service area within local councils. And I think you can see that, well, we know that council spending is increasingly focused on social care, 57% of all budgets. But if you can see the first 2 parts of this graph, you can see that actually social care has been relatively protected from cuts relative to the other areas of local government spend. And I think you can see that, and in particular after taking account of income from sales, fees and charges, which is what FSCs are. So you can see that adult and children's care spending has been protected, and I'm sure you're all feeling and see that locally. So I think the issue here is protected, but also clearly some areas like housing are very, very critical and abut upon adult social care, and particularly support at home. Next slide, please. So this is still sort of in the immediate sort of now as opposed to 2030, but I think ADASS has set out very, very clearly and very helpfully to government and those outside of local authorities exactly what's happened vis-a-vis COVID-19's impact. And some of this really comes from the ADASS summary, where obviously local government revenue sources are clearly under pressure. Government has made some extra funding, not enough. But only 4% of adult social care directors are confident that their budgets are sufficient to meet their statutory duties. So that's a pretty stark, and I know discussions are ongoing about how much more funding can be got in the short term. Next slide, please. And then on workforce, I suppose it's very obvious there's been a lack of adequate testing and good quality PPE. That's an understatement of the year. But also we now know that people working in social care have been twice as likely to die with coronavirus, in particular women working in domiciliary care. Skills for care still show the stark vacancies, which have fallen since March, but sickness days have gone up. And the Vivaldi study that some of you will have seen shows the importance of pay incentives, and in particular where staff have received sick pay who are working in social care homes, you see that service users register lower infection levels. So that's some of the impact on the workforce. Next slide. And also the backdrop here, as I say, is excess deaths. I mention this because we're producing a briefing next week, which looks at excess deaths in care homes and in domiciliary care. And we actually see that although the number of deaths is smaller in domiciliary care, actually the proportion of excess deaths is higher in that group. So it's not just care home settings that are higher risk, it's also domiciliary care. Right, so next slide, please. So let's say a little bit more about what I'm meant to be talking about, which is 2030. Next slide. So the obvious point is that there is a very large social care funding gap. You all know that, but this takes us out some of the way to 23-24, actually quite proximally. And this analysis was done pre-COVID by staff at the Health Foundation. Just to say, at the Foundation, we're also projecting out to 2030. We've got a new centre that is projecting forward supply and demand, and therefore resources needed on workforce and money in the NHS and social care, and we're doing it. And it's the first kind of proper independent analysis that's doing this on a long-term basis. So ADASS might find this a helpful resource in future. But anyway, this just shows you to the next 2 or 3 years, and you see that even before COVID, there was significant gap, particularly if you want to add in pay increases, and particularly if you want to add in increasing access levels for adults needing social care to the level they were in 2010. You can see when we did this, it looked like quite a big gap, 12.2 billion, that's the total, as we calculated then, but alongside the 370 billion that's been sunk into addressing the pandemic, you can see it's actually very small. Thank you. Next slide, please. So there's an investment gap that needs to be made up, and that's just to cope with as is, let alone any new developments. The next, of course, is probably the most glaring issues. Even if you can find the investment, can you find the workforce? And if you project forwards the jobs that are needed and project them in line with existing growth of 2.2% in activity, you find around 500,000 new jobs are needed in the social care workforce over that time. Where are these people going to come from? Over that period to, in this case, 2033 to 34. That's the big question. I'll come back to that. Next slide, please. And And you also see here what we all know, which is that the cost and demand pressures, even on existing supply and demand, is set to rise 3.7% every year between 2015 and 30 because of a growing and aging population. And that is, of course, way in excess of any GDP growth that we are going to be seeing over that time, most likely, unless things change dramatically. Next slide, please. So, ways forward to 2020. So, I think the ADASS 9 statements that were just published at 2:00 look really admirable, and I absolutely direct you to those first and foremost. But for my part, I'm standing apart from social care and really coming from another sector, the health sector, which is obviously related. It strikes me that clearly what's most important and what we're lacking here is a kind of 10-year forward view for social care. What is the strategy? What is the vision that we need, that we want to achieve? And then the principles, in addition to the 9 statements, I think, that ADASS put forwards, I think some of them are here that I've been thinking. The first one is, what is the national-local dynamic in delivering that vision? Now, the FERA, the review that it's doing, fair funding review, is also delayed. But what is the national offer in social care if the central government funding of local authorities reduces considerably? What should that be? And how does the national, if the government is committed to a more consistent social care service across the country, across England particularly, how should the national centre exert itself to assure itself that there is consistency in social care across the country and quality is maintained? So this is a big issue. It's obviously linked to funding and how quickly or not the national government can withdraw the national grant, and how far the local authority, local funding through council tax, or the revenue, or the business rates, for example, can improve. But it looks as though it can't be that all a more local source of funding just cannot cover the kinds of costs that we're going to need in social care in the future. It's just looking highly unlikely. So anyway, the national-local dynamic, I'm pressing that. The second principle, I think, which I don't think is included in the 9 statements from ADASS, is something much more about the transparency in the quality of care that is offered. And there's a huge difference in the data collected in social care, where there's enormous data deserts on the quality of care and the health and well-being of residents and people receiving social care. And of course, the NHS, it's just a different sector. But I think that is causing quite a lot of blind sight as to what's going on in the sector and how services might be improved. So that's something else I think needs to be thought about in the vision. Clearly, the whole issue about who pays and the amount of cost sharing and the amount of protection against risk has got to be part of that settlement. I'll just talk a little bit about Dilnot in a minute. How to have a constantly improving sector is also very important. And there's quite a lot going on in the NHS about how services improve, how quality of care improves, how to spot innovations across the nation and how to spread them across the nation. If something is working in Sunderland, how does it then get known about in Southampton? So there's quite a lot about that infrastructure, I think, that needs to be thought about, and maybe incentives for improvement beyond the ones we've got at the moment. And then, of course, the whole area of coordination with the NHS, integrated care, technology, and being person-centred, of course, have got to be central principles to that vision. Next slide. Thank you. Oh, okay. So I think we can miss those 2 out. I can come back to those in the discussion if needed. Thank you. So just to say a little bit about Dilnot, well, obviously it's very frustrating that some of the Dilnot proposals that are on the statute book from the Care Act are not enacted yet. It's oven ready. Government knows that. Tomorrow is the 1-year anniversary since Boris Johnson stood on the steps of Number 10 and said, we'll fix social care once and for all. This is right in front of him. It's oven ready. It's not been implemented. clearly that's in the mix for discussion. But just to say that although Dilnot is a kind of flexible means for reform, for covering of costs, it doesn't have to just cover catastrophic costs. You could set the cap level at 0, which means effectively that all social care would be free, quote unquote. So it's a flexible, it's worth looking. We did a nice briefing on this last August that if you're interested in more information that covers some of the options that the government could take here. So all to say there is really to summarise is that Dilnot is not just a cap on catastrophic costs. It could be a platform for further reform of funding, not just catastrophic costs. And clearly the other factor about financing is not just how much national and how much local financing there is of local government, of social care that is needed when considering reform, but it's also about distribution across the country. And of course, as you all know, with a move to more local financing, some areas in the country are not going to be able to cover their costs of social care, like Blackpool, Hull, Blackburn. Other areas, West London, Surrey, are going to be easily able to cover those things. So the question arises then about redistribution. And again, that's important if there is a political aim for consistent provision of social care across the country. So nearly finishing. Next slide, please. Thank you. So clearly I was just focusing a little bit on the money, just on the workforce. Well, what is really needed, I think many have said, is a national strategy for the adult social care workforce, which addresses long-term issues, not just short-term fixes. There is an NHS people plan. Something akin like that should be developed for social care, at least developed further. That should include, obviously, training and progression, but also better pay. It would certainly help to match pay increases with the NHS. And while international recruitment might plug the gaps in the short term, clearly the route to more sustainable plugging of the workforce and filling skills might well be more domestic. But nevertheless, international recruitment is going to have to be, given the numbers needed, 500,000, as I said, is going to have to be a route to pursue. So, one then has to look at immigration policy and visas and all the rest of it and what might attract people here. Thank you. And final slide. So I just want to, James, I think, mentioned inequality. And I just want to finish with this because it's quite sobering. I know everything's sobering at the moment, but this graph comes from a report called the Marmot Review, 10 years on, which we published in February. You might have seen because it was top of the news in the BBC and widely covered in the press. And this was a report looking at inequalities in health across England. And what this particular graph shows is something quite stark. So if you look at the bottom axis shows you the most deprived on the left and the least deprived on the right. The top part of the graph, that grey fuzzy line, shows you by small area in England for women, the life expectancy of those areas in the most deprived, which are at the left-hand side, and those areas on the right side. And you see the people on the right side are living longer than people on the left-hand side. And then the green area below that, the green fuzzy line, shows you the disability-free life expectancy. In other words, the healthy life expectancy of people who are according to their level of deprivation of where they live. And there you see there's an enormous and bigger gap between rich and poor, to put it that way, in that poorer people just start getting iller and having more disabilities earlier. In fact, 19 years earlier than those who live in the most wealthy areas, starting off with chronic disease, 1 or 2 chronic diseases, and then they cluster up into many more in older life. And what this graph shows you is that what we can expect at the moment is that if state pension is received at 67, at least 20 to 30% of deprived individuals, of only the least 20 to 30% of deprived people living in deprived areas will receive a state pension. So most people, in other words, will become sick and dependent well before they receive state pension age. About 70% of them will become ill before that happens, before they reach 67. And I think that's quite sobering. So that really underlines the need for prevention support and support in the community and boosted domiciliary support, as well as much greater prevention in the health sector to help that out. So thank you. That's all I wanted to say. I think my 10 minutes are up, but I hope that helps in the discussion to provide a few bits of pointers of information.